therapy, psychotherapy is increasing. In 2000, occlusal treatment is prohibited, dangerous. Splint is decreasing, and it is a period for physiotherapy. Currently, from my point of view, occlusal treatment is little bit increasing because our knowledge is better to know when it is indicated. Splint is decreasing, and physiotherapy is increasing. The important question is concerning invasive treatment versus beneficial treatment. We expect positive therapeutic benefits with a minimum of cost. It is clear. Sorry. The choice of the treatment are the analysis of the balance between the capacity, the problems, the constraints, following axis 1, axis 2, axis 3 of the patient, and the capacity of tolerance. And the treatment is to increase the capacity of tolerance. If you increase the capacity of tolerance, you reverse the balance. And you can increase the capacity by psychological resilience, by exercise, sometimes by biological treatment, and sometimes by structural optimization. That means, for example, by occlusal treatment. But it is not the only way to touch the teeth, is not the only way. When we have a problem, we are looking for a solution. And the simplest way, it is like in a labyrinth. If you are in front of a labyrinth, the solution is going up. And look the thing from a drone view. And you see the way to go. So that means we have to think globally to your patient. That is a drone view. Think globally to the patient. Don't forget the 3 axes, not only the mechanical axis. Sometimes you can open a therapeutic door. That is active treatment. Sometimes it is interesting to go directly to the solution. But sometimes it's not necessary because that is invasive. And with invasive, if you have not, it is not necessary. If you can have the solution without invasive, you can go by the solution, therapeutic solution without invasive treatment. You have to go. Okay. It is the reason why the first treatment is a treatment type A. non-invasive explanation, counseling, cognitivo-behavioral therapy, and physiotherapy. Possibly the second line of treatment could be splint. Splint is indicated in first intention only in acute phase. And rarely dental change on healthy teeth. 1, 2, 3. Underlined on healthy teeth. If the teeth are in a bad situation, in bad position, in a bad status, the things are different. Okay. In some cases of TMD, there is emergency. And first, counseling, rest, behavioral advice, and honest ideas. It message for muscular TMD, sometimes intramuscular anesthetic injection for muscular TMD, and gymnotherapy. Even in acute phase, mandible must be mobilized gently, but we need moves. Move, decrease inflammation. Gentle movement, decrease inflammation. Sometimes anterior occlusal stop, most often for muscular TMD, and sometimes posterior occlusal stop by bonding composite for TMG capsulitis. Anterior stop. The NTI here is only if you want to spend money. It is more easy to take a piece of light cured resin like this. Well, we have to look where are the weak points of the masticatory system of the patient who is in front of you, and what are the therapeutic targets. More easy to reach. I would like to show you some patient case now. This lady, it is muscular TMD, primary muscular TMD, with a strong psycho-emotional component. The opening is 38. It is little bit insufficient, with pain during the opening movement. We have pain, temporal masticatory pain. Sorry. The pain is from many years ago. We are in a chronic pain. Recent sharp pain equal emergency. Chronic pain equal think about before to put your fingers into this case. We have to help your patient, of course, but quietly. Even the patient present a strong pain. My question, when a patient said, "Oh, doctor, I have a very strong pain. Only you can help me." Okay. From many times do you have this pain? Oh, from 5 years. Okay, it is not an emergency. Understood. The axis 2 here is the main problem. And before to say to the patient, oh, we have to make a lot of dentistry to make surgery, perio surgery, to make orthodontic treatment and prosthetic treatment on all the teeth. Before this, decrease the dimension, the psychological dimension by confidence, by more understand the patient with contact with the general medical doctor of the patient and so on. No emergency. We have time to treat it, to treat it. A splint can help this patient, yes, for few weeks. And if you ask to the patient, do you have a splint before? Oh, yes, I have 4 times, four or 10 splints. You understood that first. Think about the psycho dimension. Another case, it is a young lady with a systematic joint laxity. And you see the systematic longevity by the quantity of the translation, the condyle. There is a small click here. It is a click of over-rotation, subluxation. And this laxity, hyperlaxity, is in relation with the systemic biological dimension. So that means we have no tools really to treat it. But it is not a problem, real problem, because there are no real true luxation in this case. If you look, in fact, this patient has asymmetry of the face. But just counseling for this patient, she has no pain. For this lady, she is approximately 50 years old. It is a muscular TMD. Joints is okay with a strong occlusal component. It is there is a mechanical problem here. Limitation 29 millimeters of opening movement. With lateral protrusion normal. That means it is not a joint problem. It is a muscular problem. And when you look at the occlusion, It is ICP, no contact on posterior teeth on the right side, and no contact here on the left side. It is RCP with a strong prematurity here. With a decentering. We have really a problem of stabilizing function, occlusal stabilizing function, no posterior support. We have a problem of a centering function, transverse discrepancy between RCP and ICP. And it is recent. It is natural dentition. Not at all. There are crowns on all the teeth, and the patient has implant treatment maxillary on maxillary posterior part recent. So that means in this type of case we have a green light to change something on the occlusion. To give stabilized support in centriculation. And what type of treatment I done here? Just anterior and 2 or 3 crowns here. I don't remember exactly. And occlusal adjustment on the posterior part. And the patient open normally without pain, very quickly. Another patient. It is she is a 40 years old. Right pain. Oh, sorry. Around the TMJ. With a clear deflection on right side on opening movement, which is limited to 21 millimeters. The lateral occlusion on right side is normal because the left joint is normal. The lateral occlusion on the left side is limited because on the right side we have a disunion, total disunion on closing position and total disunion on opening. That means a total disunion without reduction. It is a grade 3 sharp situation. And you can see the limitation here. Continuous pain increasing by function. When you palpate the TMG, it is painful, so it is a, a sad signs. It is TMD. Recent orthodontic treatment and a very poor situation from periodontal point of view. What type of treatment? Emergency treatment on the first on this teeth. There is caries and problem of instability, occlusal instability. Don't forget first the teeth, perio maintenance, cognitive rehabilitation by behavioral treatment to put the patient in confidence. She is very afraid by the periodontologic situation after orthodontic treatment. And the orthodontic treatment was done to treat his TMJ problem. Gymnotherapy, reassessment after 40 days. After gymnotherapy and, cognitive behavioral therapy, opening is 28. Splint, reconditioning splint. Yeah, the opening is 37. Do you think the disc is coming back to the on the condyle? The answer is no. We are looking for adaptation of the tissue. Another case. Linda, 56 years old, with a pain on the left TMG, clearly on the left TMG, with a crepitation sounds. She had also occipital cervical pain. Yeah, with pain. Yeah, she had a limitation of the function and prosthetic demand. An historic chin trauma 30 years ago. Look at the radio. What we have? Oh, we have something. Yeah, we could have something like a risk of interference. Yeah. No posterior support. Not really posterior support. Yeah. If you look the condyle, it is morphology of normal condyle here, and eminence too. Probably normal situation on the right side, and you can palpate the condyle with of movement. I appreciate the capacity of translation. Yeah. Uh-huh. We have a flat condyle and probably a flat eminence. It is a painful area. It looks like a grade 4. The ICP, initial ICP, the cast, and we can see here it is not a strong posterior support. We have also Braxton's facets. Here it is a questionnaire of the patient, and she says we have symptoms described by the patient. Crepitation on left. So, TMG pains, but not continuous. Important cervical pains. Tinnitus, stronger on the left side. Discomfort during the movement. Okay. The signs, positive signs. Deflection on left side with limitation of the open movement. Crepitation on left side. High density of the masseter muscles. That means clenching. And the lateral occlusion on the right side is limited compared to the lateral occlusion on the left side. On the left side, 12 millimeters because the right TMG is okay, and limitation on lateral occlusion on the right side because the left TMG is probably with a problem. Sorry. Okay. If we compare on the articulator ICP and RCP, we have a little, very little transverse displacement. Okay. That we suspected by the clinical examination and panoramic radiography is confirmed by the condylography because we have a limitation of the translation of the left condyle with a flat eminentia. This one is probably a sagittal condylar inclination of 25 degrees. This one is typical of a grade 4. That means osteoarthrosis of the left joint. And look at on the CT scan osteoarthrosis and remodeling of the eminentia. That means grade 4. Perhaps it is origin is post-traumatic. So it could be a secondary temporomandibular disorders. But we have not the primary treatment. We cannot treat the traumatism now. So we have to treat the sequela of the trauma. The patient has another documentation with a scintigraphy, and we can see a spot of active inflammation on the left TMJ. Here also. I'm so sorry. Nobody? Okay. What type of treatment? Physiotherapy, gymnotherapy, and prosthetic treatment. No surgery and orthodoncy. No occlusal adjustment. No splint. Because the patient need a treatment, a prosthetic treatment. Because the dental status. If you look, here we have something to do, and this part here is not good. So we have to treat this portion from prosthetic treatment, this portion for by eventually orthodontic, implantology, or classical prosthetic treatment. So we have a green light for prosthetic treatment, which is not invasive. No, sorry, which is invasive, but without overcost. And it is a treatment, 2006. And the patient opened 45 millimeters without pain. Even she had a strong osteoarthrosis. Osteoarthrosis, the limit